Here we are back for another fantastic conversation. How have you been, Renee?
Hey, I've been good. How are you?
Fantastic. You know that it's mid-April now, and so that means I can officially start planting. The federal crop insurance dates have passed. So I am in the field, I hope, here very shortly.
What a great day. What that means, as we've talked about this before, that means the legislature should have an itch now to start moving toward adjournment because they too can be out in the fields. So the warmer the days, the sooner the spring, the more likely we're done with all the goodness going on at the state house at the moment.
I'm
And
not
not just
holding
our
my
state.
breath. I'm not
Hey,
holding my breath. So
well, it's been a fairly decent spring. So, I mean, maybe there's time to be able to plant, and they all see the same dates you do. So, maybe there's going to be movement. And that's just not us. I mean, that's multiple Midwestern states for
oh,
sure on that same calendar for the same purpose. And if you don't know this, but if not, everybody just goes home to plant. And then basically you have to decide what days you're coming back in to vote. So, everybody's gone for multiple days. It's like, we're coming back in on Thursday. It looks like rain. Well,
oh,
how do we let the farmers rule the world? I don't understand. I know you understand, but I don't.
I do.
Well,
I get
I
it.
know. I know. So today we're going to continue our conversation about what should be in a mental health system. And we've been moving our way through. And last week we talked about residential facilities, and we had tons of acronyms last week. And this week we kind of really only have one, and it's in our title. It's an MHI, which is a mental health institution. And today we're going to talk about what those are in addition to state hospitals and how they kind of fit into that acute care setting. We're going to talk about that. We're going to use Iowa as a pretty big example today of a system that has some definitions of how things work and how it should work. And then we're going to talk about some of the states we've worked in where there may not be as many clear definitions of what's going on. And it causes a lot of confusion. If you don't know what's in your hospital or who's even paying for the hospital, things get kind of out of hand. We're going to talk about that. And then we'll get to the end just talking about, some of the things that are going on in the news that are kind of coming from this movement. So, Jason, I know that some of the conversations about state hospitals and mental health institutes in our state, some states have tried to get rid of them or to close them, and it's kind of caused some havoc. So, what is a state hospital, and if you know, what do we use them for? What's the point of a state hospital? And I know, as you know, it's come from a very, very long history. So, what it used to be and what they should be used for today are not the same. So, tell us what we're talking about here about state hospitals.
I feel like that's a loaded question, Renee. So let's
It
just
kind of is.
start with what should a state hospital be, right? And
All right.
so when we think about a state hospital, we do get that image of an institution, right? And so there are a certain percentage of people who are very hard to treat. And so at the end of the day, it's the state's responsibility to provide a safe place for folks who need some really intensive treatment, right? And
Mhm.
so I think the state hospital as it's evolved, is supposed to be that place of last resort for
Yes.
folks who don't have any other funding, who have really difficult to treat mental health conditions, multi-occurring conditions that need a lot more support and structure. Now, unfortunately, what we've seen across the Midwest and across the country, let's be honest, is that, we kind of went through a period of time in our history where institutionalization occurred. And so we had lots and lots of people placed. Some of those people never belonged, never needed to be placed for long term into that
Mhm.
type of institution. And so, the goal is, I believe, and I'm being pie in the sky, right? That it should still not be a long-term placement. It should help to stabilize someone and then help get them back into a community where they can thrive. And that may mean they need a lot of supports, right? Going back to our last episode,
Mhm.
we talked about all of those intensive supports and communities that can be there to help people
Mhm.
be successful. Unfortunately, Renee, do we really see people transitioning through levels of care like they're supposed to?
No, we don't. So I know that you would say before we even start this conversation that really state hospitals and these are kind of like you said last resort, and you really should have tried other levels of care before you've gotten here. And in our state that really is true. You cannot just go to a state hospital or institution unless it really is the place of last resort. And what frustrates advocates and families is that means many, 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 many failed placements
Right.
before you get there. And I get that from a family perspective, that must be awful. But at the same time, from a state's perspective, it is a level of care that is, you're looking at the least restrictive environment. And so you really are trying to make sure that nothing else works before you use such an extreme measure. This really should be considered an extreme measure, and which is very different than the way it was built up in the day. And we could do a history lesson on mental health institutions. I think they're fascinating. And I know I've said this and I'm on record for saying a couple of them could be really amazing haunted houses. They are the most creepy places I've ever been. And I think we could really capitalize on that in our state. And that could be a tourism thing. The state of Iowa should jump on that. But anyway, for what I'm talking about today, the ones that are still in existence, I mean, there's amazing people that work there, because you are the top of the top, cream of the crop kind of folks that work in these institutions, because this is really the really tough folks. And so now in our state, we have two. And so Jason, I know one of those is over in Independence, and that one has the children's unit. So what does that state hospital look like as far as what services are provided in that hospital?
Oh, here, you said, what does it look like? I'm just thinking, I was just there to do a training here not too long ago. So I have the images going through, and that's part of, you talk about the, the old big brick buildings, they're not, and they're very well taken care of. I have to give Iowa credit that they do the best they can. Yeah, I think you talked about those kids who have really complex needs beyond those. If we go back to the last conversation we had, who could be served in another organ, like a PMIC, a psychiatric medical institute for children, right? So it's beyond the level. And, I think it's important we talk about where acute care hospitals fit in, right? Because we need to think about that, hospitals are there for typically that short-term stay, right? To stabilize someone, if someone's suicidal, to make sure they're in a safe place until that suicidal ideation passes, to stabilize someone on medication, which could be up to 2 to 4 weeks, right? Up to 30 days. But really anything beyond that, your acute care psychiatric units in your local hospitals in communities across the state aren't really set up to manage that, right? So those are those more complex cases that then should transition on to someplace like Independence, right? Who has specialized units to help individuals and children with more complex needs. And so I think it's important we understand the steps in the process, if the system is functioning well, of how people transition to the right level of care at the right time for them.
Yeah, we talk about Independence, and just like you had an image pop in your head, we did too. One of our foster children that we had when we first moved to Iowa years ago now, we were what was called a therapeutic foster family. And basically my full-time job was to take care of two kids who were coming out of really high levels of care, with the goal of stepping them down into lower level of foster care. Because at that point in time, that was sort of the federal idea, was that could work, that you could give them more intensive wraparound services in a home and then transition them to more of a longer term placement in foster care. Well, one particular child, that just did not work, and I had to drop them back off at an MHI, and that is a forever sealed memory in my mind, because felt like leaving them in that big stone cold building was just tough. But man, the people there were so good. Like I said, the staff is amazing in what they do. They have adults there also in Independence at our state hospital. And so they're working on now, just recently shifted this around, where the Independence one does children and adults being more of that complex needs. I think they increased some beds over there too, to add some more adult space. And so they're trying to really kind of combine who is there. And then the second one that we have is in Cherokee, Iowa, and it is a different mental health institution. And they've changed this one. This one used to have adults in it as well, but now they're moving toward more of acute services related to competency. And for those that aren't aware of what competency is, if you get arrested and you have a trial coming up and you may not be of a clear mind to be able to stand trial, you are then held for competency. And we have learned, Jason and I have done some work now around the Midwest, and are learning a lot about this topic, but we're learning that there's outpatient options for this. So some people can be pretrial release and doing their work in the community and whatnot as they're working on their competency to be able to stand trial. And then there's others, though, that are incarcerated and need to stay under protection, whether that's kind of in a civil or they're maybe adjudicated to jail status or whatever. So our human services department has this particular facility now that they're using for competency. So what that means is they have training there for folks that are in that forensic psychology type space, where the idea is to help people improve to a place where they can be considered competent to stand trial. So that could be, getting them off whatever substances they were on so they weren't making mental clear pictures of thoughts, or maybe getting them on medications to stabilize their psychiatric situation, or combination of all of that, or physical ailments that might be something that needed to be cared for before they could go to trial. So the Cherokee MHI now in our state is working on forensic. And there's a second one of those that's in the prison system, also, I think, run by Human Services, but it's in our correctional facility over what we call Oakdale, or over in the Coralville, Iowa area, that also has so many beds, again, that do that as kind of a smaller hospital. So there's a lot of folks that stay, and if you don't, you just end up in jail for a long time. And that's not what we're trying to do. We're trying to make sure people get the health care they need so that they can make a decision one way or the other where they're moving through. So we do have those 2 state hospitals. But Jason, when you're walking around and working in the other states, what do you see in other state hospitals being used for?
Yeah, and so I think it's important to note, though, with competency restoration, that's typically a responsibility of the state, right? And that's kind of typically one of the core areas when we go across states and we go into institutions. And we've been into state hospitals in multiple states. I've got one scheduled coming up where I'll be in another state, in their state hospital. And when we go into those facilities, there's a core group of services that only the state can provide. They're not part of Medicaid. They're not part of any other privatization, that generally it's those types of services that only the state can do. And so that's where it gets problematic at times, when there's a lack of definition of what these state institutions provide. I mean, we've been to several state hospitals where they're not only a state hospital. We talked about Iowa's done a good job of differentiating. Like,
yes,
you have to go to somewhere else and meet a criteria. We've been in other states that the state institutions, also the local acute care hospital, like people literally just get dropped off in front by the sheriff. And they're now the hospital, but they're also then providing intensive needs for complex patients, and they're providing competency restoration to someone who's in jail. And so there's just so many things happening at the same time, and they're not happening timely. And then you get this backlog of people. And so it gets so confusing. And so literally you've been to one state hospital, because it's a different array of services in different states. And that only adds to confusion amongst the constituents in those states, because so oftentimes, we'll sit with legislators, Renee, and several times we've been with legislators like, we don't even know what they do over there.
That's right.
And we're like, well, I'm not sure we do either, but we'll find out for you. And it kind of blows my mind of how can people not know, but that's how confusing these issues can be.
Well, and you think of some things that maybe worked or didn't work, but I think our state neighbor to the north in Minnesota, I don't remember how many years back, went from one big state hospital to the idea of having 10 of 16 bed units around the state, which the idea, again, we've talked about this in previous episodes about the IMD, or the medical exclusion that makes it so we can't use Medicaid dollars or federal monies in facilities over 16 beds. So they went from a model with the idea being that, well, they were going to bring beds closer to home to all of those different areas. There were going to be 10 of them across the state. Well, 2 of them or something never even made it at all, never got started. And then the ones that are left, still everybody's coming basically from the Twin Cities to fill up all the beds in all the places. So even if you are in your local rural community where we worked a couple of times, they can't get people in. And so the design still didn't really meet what they were trying to do. And instead of doing like Iowa trying to specialize 2 hospitals to do 2 very different things, Minnesota's trying to do all the things in all of the things. And I don't know that that's working better for them either. But, so all states are sort of grappling on this topic of what to do with a state hospital or not. We worked in a different one that tried to get away from a one state hospital that tried to go regional. And you and I did not recommend that because of workforce issues and just a lot of things. There would have been as much challenges as we're seeing in places like Minnesota. So this is an issue, you're right, that the state is responsible for certain types of care for its constituents. And so the states are all trying to figure out, okay, how do we do that in a way that's responsible fiscally, but is also, the things only the state can do, and what other things can the private sector do that they can do. And that is troubling to advocates and families who think the old way, where a mental health institution is a place for people to go long times. They used to just go live there for a long period of time. And so we still have that mindset and that stigma, especially in the older generations of people who think the state hospital should just be the place for somebody to live forever. And that is absolutely not where the federal government wants it to be or where any states want it to be. There could still be a couple of those around because we haven't been to all the states yet, but generally speaking, that is not the thing. And so that change has been hard, I think, for constituents to understand what the state hospital is for.
Yeah, and I think that part of that then lack of understanding is why we get into these issues. And so I'm just looking at one state right now, and the average wait list time is 169 days for someone to go to the state hospital, which means that people are backed up in local community hospitals or other inappropriate levels of care while they're waiting for that bed. Right. And so I will reference as well, because I think it's applicable, is we're linking to this the vital role of state hospitals from the National Association of State Mental Health Program Directors. And it's a few years old, but it's a really great document. If you really want to learn about what the recommendations are of what should a state hospital have from that association, I think that, that spans the country and kind of has the top thought leaders saying this is what we should be doing in our state hospitals, and then overlay that with what you see happening in your own local state hospital.
Yeah, I know this has been kind of a somber conversation, but Jason, please tell everybody about the story of the state we were at where they had the substance use beds inside their hospital, because that's my favorite story.
I don't even remember that one. Yeah,
we had a state hospital, and right, I mean, you were trying to track beds. We've talked about this a little bit in a previous podcast.
They told us they had so many beds, and we went from facility to facility to identify where these beds were, because they didn't understand. They would count beds 3 or 4 times. And so they said, well, we provide substance abuse treatment. And I said, how do you provide that in a state institution in a locked unit? That doesn't make any sense to me. And so here they were counting substance use beds alongside their state institution beds, alongside acute care beds, because it was also the local community acute care hospital. And so literally they were counting the same bed 3 or 4 times at 3 or 4 different levels of care. And then they were like, well, we have 500 beds. Well, in reality, they had 50 beds because they counted the same bed so many times, which then they couldn't figure out why they couldn't serve people. Right. And then their resources were all out of line. Their budget was all out of line. And it was so confusing to unravel. Literally, it's like peeling an onion. Every time we'd learn one thing, it would make something worse on the other hand. I remember just sitting and just nodding my head going, this can't be. How did all these really smart people end up in such a horrible position of forgetting and not understanding how to serve people? And so that happens over and over again. Like I thought, well, this can't be true. And right now I'm in another state and we're doing the same thing all over again, Renee. Yeah. And it's painful, I tell you.
It is. And if you listen to our last episode, we talked about all the acronyms, and that just is exactly what happens. People don't understand the acronyms. They haven't defined what service is at which level of acronym. And so then you get into it and you just don't know. But when you get to a state hospital, and then there's very restricted means of how you get there, and then you put it on a public document with a star as if that's access to beds, it's not a thing. And so, there's the state gets upset. They don't understand why constituents are so mad. Well, constituents are saying, well, you're telling us there's 20 beds accessible in this location, but to get there, there's all these hoops to get there. And so it's not really access. And so there's a definition block just about what is access and what is not. So I know also in the show notes, today we just have full of notes of things. If you're interested in this topic, you could dive down deeper and talk about it. But there's another document that talks about trends in psychiatric inpatient capacity. And just off the top, we're going to talk more about this in an upcoming episode, but what are the trends that we've seen over time? This particular document goes over decades. It goes from like 1970 to like 2018. The general trend is that the state itself owns fewer beds, and they've privatized more beds in most states. That's a true statement across the board. And it had a lot to do, again, with the IMD exclusion, that mental disease, the institution of mental disease, that you could not get federal dollars in. So most states don't have really big hospitals anymore. They just keep people in them because it wasn't funded well and it didn't make a lot of sense. And so where did the people go, Jason? We know where the people went, but where did the people go that we let out of all of these institutions?
Well, I'd like to tell you they went to the community because they had increased supports wrapped around them so that they could be successful. But I know that's not the answer. I know the answer is all these people went to jail and prison.
And how do we know that?
Well, we know that because of the data that we
Yes.
see all the time of what 80% of our prison populations have a
Yes.
co-occurring mental health or substance use disorder. We've
Yes.
seen an increase in law enforcement activity for those individuals. Competency restoration,
Hmm.
we know in several of the states we're working in, is up 2 to 3 times what it
Yeah.
was even pre-2019. So all of the trend lines are going through the roof when it comes to unserved individuals with mental health conditions, SUD, in the community not being served to the level they need.
Right. And I know in some of our work with critical access hospitals and in one particular community, there was that such a divide between the emergency department at the hospital and the jail. And their biggest fight was that the jail was bringing on social workers and people to treat folks with mental health in jail because they couldn't get them any kind of services at the local hospital. The critical access hospital said, that's not what we do, not our job, and we would just go back and forth. And so jail decided, well, we're going to have to take care of that. We were in a different state and we toured a jail, and some of the best mental health care in that state was also in the jail, in the prison system. And our state, I've heard amazing things about our prison system, mental health. They're amazing people. And sometimes people are like, that system's better than in the community. And that's really, really sad. It's kind of backwards, and we're going to talk more about this in an upcoming episode, sort of a deep dive. But when everybody thought that we're just going to let people out of institutions, and the trend data will show, and it ended up two different places, either incarcerated or in many cases without a home and be on the streets. And so I'm thinking of some of those, we think about stories related to this. Jason, I know we've got a really good friend that's advocating for additional beds at the state hospital, and it's been such an uphill climb. But if we've both heard her speak many times about it, but from her perspective, additional beds that only the state can provide makes some sense. So do you know exactly kind of where she's coming from with that specialty care perspective?
Yeah, I mean, there's some things that only the state can do, and the state can do it best if the state stays focused and has a clear, defined goal, mission, vision, and principle of care to get that done, right?
Mhm.
And so I think that's the balancing act is how many beds are the right beds, and how do we hold accountable those providers in local communities to do the tough work they have to do and fund them to be able to do that because it's all linked to a continuum of care. And I know we talk about this all the time, but unless you have a true system of care, a continuum so people can step up and down to the level of care that they need, none of it's going to work. You can build all the beds in the world and it's not going to work. But I will say you can make a difference by advocating.
Yes.
I was just looking at a website here, and suddenly one of the states we were working in, they suddenly have a mission and vision of what their state institution does. We couldn't
Amazing.
find it. We actually
Amazing.
requested it a few weeks ago, and now suddenly it's on their website.
That's
Um,
awesome.
so one person can make a difference, right? You ask a couple of questions of a few of the right state officials, and suddenly the website's changed. Suddenly, now it doesn't mean it's what it should be, right? But at least there's something, right? At least there's something there we can start to work with. So I want to remind people like advocates, we talk about advocates who are out telling their story,
That's right.
right? This is why we should be doing this. This is why we should be having these conversations because one person can make a difference, right?
That's
And so
huge.
that's how you start to snowball and impact an entire system. And that's why we do the work that we do is because we want to impact systems and make things better. And that means changing laws and doing the stuff that some people really don't like to do, right? You got to dig into the detail and it can be really boring sometimes. And it can feel like it takes years and years because it does. It takes years and years, sometimes decades to change systems. But it doesn't mean we should give up and say, it's too overwhelming, I can't do it, because you can do things incrementally and you can start to see those changes happen over time. And that's really the exciting part we need to stay focused on.
Yeah. Well, today we're going to focus on the recovering politician self-care policy of the week. And last time we talked about delegation as a self-care tip, but this time I have a favorite topic. It's called deletion, or just delete. So I have a tool that I don't know if everybody has, but if you don't have one, you need to. It is called my not to-do list. not just like a to-do list with all the stuff you need to do, but this is a list that you're intentionally thinking through. What are things I shouldn't be doing in the first place? What are the things in my life at this stage, in this season, that I really need off my plate for whatever reason? Maybe it's a season that is just more busy. Jason's heading into planting season. There's going to be things he cannot do everything. So that email he wants to send and he wants the waiting on somebody else to do it, that's not going to be a choice here coming up because he's adding planting on top of a full-time job, on top of parenting, on top of. And so sometimes you have to sit down in your season and go, okay, what's on the list for right now that I am just not going to need to do? And then you have to start thinking about, well, is it important enough to delegate like we talked about last time? Or is it something that's just not useful at all? And for myself, I have things like scrolling on social. There's nothing valuable about that. And I probably do way too much of it as far as something I just spend time doing. That should be on my not to do list. That should be the absolute top of the pile of stuff not to do if I'm overwhelmed or have too much on my plate. That's an easy one. Nobody's harmed, no foul if I never do it again. And so those are things that, you think about, maybe I'm doing too much of blank and I should stop that. And so it just removes distractions. It removes clutter from my mind. So what about you, Jason? If you could think off top of mind, you may not have ever thought about a not to do list, but off the top of your head, is there things that you're just like, if I didn't do that anymore for right now, while I'm heading into planting season, that's probably a good thing.
Oh, it would have to be the doom scrolling, right? I love those construction video fails. I watch those reels over and over again, like the cranes falling over or, the tractor going in the ditch. You could watch those things forever. You start watching one and then suddenly, 20 minutes in, you're still watching these ridiculous videos from other countries of, horrible construction accidents and fails. So, are those time wasters? Absolutely. Every now and then, do you need just to, get your mind somewhere else? Absolutely. But there's a lot of wasted time, right? And so when I think about how to most effectively use my time, I think we all in this day and age have to take some accountability for the doom scrolling that's going on.
Yeah, agreed. Well, today we did a little deep dive into state hospitals and tried to share what we do in our state in Iowa and how we've got some very specific ideas of how to use our state hospitals, in contrast to some states we've worked in where they don't really know what they're doing with a state hospital. And the fact that we've got tons of resources for you to see how state hospitals have changed over time and what the purpose of them should be today, and really should be thinking about the thing only the states can do. Those are the things that should be done in the state hospital. And they really are an integral part of our system, but we need to do a much better job of explaining to folks how they fit in the system, what the access criteria are, and how to utilize it, because that's where the disconnect comes, where the public thinks it should be done a certain way, and the state's saying, well, actually, it's done this other way. And if you don't tell each other that, we don't tell each other the mission, we don't tell each other what the purpose is, then people get very upset and confused, thinking that they should have that service available to them when maybe it's not even reality. So that's what we were discussing today. When we come back next time, we're going to dive deeper into our children's mental health system. Just what is it? How does it work? We'll see you then, everybody. Have a great day.